Hello, everybody. Welcome back to lunch. I hope you all enjoyed yourselves. We're going to get started on our afternoon session today. The first session we have is on lead poisoning and prevention. No safe lead level in children has been identified. Sources of lead exposure include lead-based paint, drinking water, contaminated soil, consumer products, and lead exposure through jobs or hobbies. Tribal lands are often in rural areas where there is a greater risk of lead exposure due to subsistence practices. Lead screening and prevention programs are critical to address childhood lead exposure among American Indian and Class C natives. The presenter today will be discussing how to reduce childhood lead poisoning as a public health problem through strengthening blood lead testing, coordinating and surveillance, linking exposed children to recommended services, and targeting population-based interventions. Our presenter today is Dr. Paul Allwood. Dr. Allwood is the branch chief of the Lead Poisoning Prevention and Environmental Health Branch within the Division of Environmental Science and Practice at NCH. Prior to this position, Dr. Allwood has served as Assistant Commissioner of Health and Deputy County Manager for Health and Wellness in the state.
Good afternoon, everybody. All right. Well, it's a pleasure for me to be here on my reservation. My previous role at state government, I was fortunate of going through tribal relations training at the time I worked for Minnesota. The then governor of Minnesota has made it a requirement that anybody tribal relations training. So that taught me a whole lot. It's something all of things. Great level of appreciation for tremendous history, culture, wisdom that it's part of the native work. It is very so it's always a pleasure to come and share with. Before we get started with my talk, just give them the context. Everybody, to just a little demonstration. And to kind of get everybody up and maybe just try to make it. So everyone can stand. This won't take very long. And if you've done this before, and you know the other. So what I'm going to do, if you have any kind of everybody just yeah, and then but just a little more, just a little bit. All right, no, you can always say and that demonstration is just perfect as human beings. You can always do a little more. When I said to everybody, what happened, and people really did that, and then I said, go a little higher, and it's try but that was a really focus too, because if we're asked to do a lot more, then maybe it isn't so appetizing. But if we mentally so the talk today is how lead poisoning in the 21st century. Just because we're a small audience, I'm not trying to make this as direct as possible. So first thing I want to ask anybody, what comes to mind for you when you say type 1? Childhood lead poisoning. That involve any kind of reactions, feelings of 21st century. Yes. I think you were first. It's a really good point. Any other thoughts? Yes. Yeah. Yeah. It's sort of an indication. These are all great answers, and I thank you for what I'm going to do is talk about childhood medical is important, and I will have plenty of time for discussion. And we'll do some more knowledge points. Let's get everybody interested. Maybe that should be a Friday. If you're inspired to come up and join the fun. So I'm not going to say too much about this. You've heard a lot about it. Everybody, is there anybody that is in the very head? Oh, okay, all right. Then I should just say a little bit. So, that is mental. It's why use centuries for a lot of different things. And, just for as long as it's been used by it's been known that it's if you're starting to think on Earth, there would, a lot of people go crazy and so you knew that it was it's been used something that, not only persistent, but it also increased. So over time, it's led to widespread so if you would read your advances, oh, it's over there. Sorry, you just keep the next one and slide.
Maybe.
All right, so just to kind of further read this is that global. In 2022, we published 61 articles.
Oh, yep.
In 2022, they
Get like fell asleep because you didn't touch it for so long.
Published a special edition in the American Journal. And this was just called attention to the ubiquitous nature of that as hazard that's very widely used, rooms and just other thing. There is the potential on the screen, you'll see that there are some common sources that are identified. And very certain to most of you, this is surprising that because sometimes the source is clear is complete. So I would recommend that's continues to be a source of exposure in water, and to really application issues badly because of the water solutions. And also some other consumer products, toys, jewelry, and feeds, for food, certain jobs, hobbies. And so now another little test for the audience. Is there anything that you are aware of that's a source of lead, that's in the home or permanent? It's a source of lead that's not on this list. You think it just
Yeah. My daughter used to like turtles, toy turtles, where the sections and have a lot of them, I don't know. That say that it's something.
interesting. There's something else that is in a lot of homes.
Windows, I think about it.
Yeah, Windows and Suite page. So yeah, that's a good one. That is great. That's why I was thinking about something else. It's fairly common for movies. Pottery is up here on this. Pencil, that's not guess, but pencil actually, they're called lead, that's I was thinking about like fishing tackle. So it's a really wise. So people to the next slide. So we don't know that like
No, I actually hit that button. I unlocked a new button on accident.
If it's detected in a system, it's going to be navigating text. I love the systems. Used to be that, back in the days when, it's very complicated, kids would show up. That they have led, that's the last night, that's typically items such as a house to be able to, or live in a house where, they let just for so long. When you test that child, that's not so common anymore, but there's still some cases that it's really we're most today more than this. Later on, he was talking, I'll show you a slide. I'll show you where it comes from. It's and where it's in. That slide has the good news mentioned. So if you want to, there's some data text there. Next slide. We were really interested in the picture for a number of reasons. And you can see them on the screen. Kids are still developing their constellations. Their blood-brain barrier is still developing, neurological systems are still developing. Their lungs. They also breathe more pre-antibiotic things than that counts. They're crawling, they're lower to the ground. There's a lot of reasons for this. So we need to be a high priority for us. Next slide, please. So this is the slide that I kind of now, you can see here that first one is this. Solid line is you can see, both the curve and large that nice. Similarly, the dark line, which is same measure. Back in 1966, the average level in a 5-year-old a child on Earth. Today, that is and kids are a little bit more different. 12.7. 2016, you can see the levels were down to that's the good news. That slide is that at the same time we've also recognized that even those very low, still significant. So while we can kind of deal with that, that's largely due to such as negative pain, there's other there's a whole lot there that we keep about here, but we also even these low levels are very good. Okay, next slide. All right, so the other dimension of the ongoing persistence that it has a really striking disparity dimension. And it's kind of interesting because I like to say that when is both yourself. So it's kind of like no are exposed to injuries that will make it difficult for them to payments, and economic success. There are some economic determinants for them. So that leads to kind of a circle where there is both cause and result. All right, and you can see here, next slide. I think I'm going to just sell one item. One of the previous jobs for Tony organization, and I was responsible. Needed corrections. Which is kind of new because my public health education community is here. I happen to be visiting a boys correctional center. And there were 15 youth in that facility, age 11. And it was Martin Luther King Day 2019. Went to visit. And the official of the facility wanted to display how much progress were making. And so they had them read and write sentences. I was really taken back that very few of them needed, simple sentences, a whole lot of exposition. They all look like me, and I knew where most of this came from. I know the communities and the housing. It wasn't until later that this I realized that's probably a very good manifestation of arts on like which for a lot of those youth. Fortunately, while I was there, but we do know that exposure is social harm and malignancy, creating violence. Just thought I'd mention that. All right, so this more or less kind of sets up our other ways of a lot of cases. We all know that whatever level, and we know that multiple sources. All right, I'm going to switch on that. We know lead-based states, criminal homes are ban on paid, in consumer paid. Can anyone tell me? That's a discussion. Is there still lead in states? I mean, like, are we still allowing lead to grow? You're nodding over there very confident. Yes.
Highways. The paint you see on the road.
So the paint that we see on like bridges and other types of that's still allowed. What happens when like when a bridge collapses or doing renovations to the bridge or just normal process of nutrition? What do you think happens to somebody? Exactly. But yeah, this is a really great response. Yes, we see the loss there. So from the exterior, we heard a lot of story. Still, Flint crisis really squarely consciousness and just gave your sense of quite heavy, is definitely there are some sources that may be more likely to be a problem. is really good. Older housing, it must mines and servers. Yeah, also know just because we're very good and for state that there are urban marketing city of Minneapolis that live in also live in communities where there are there is of course maybe working on more construction. Water sources are not going to be water nor regulation of continuing to harm people. Consuming wild game is also a source of radiation. Two we talked about the fish. These are just some sources that maybe more people with. No, I'm scared because I don't like, some of you are. Is there anything else that you know or aware of as a pretty significant source of tribal communities that's not on this list? And I think of something else maybe that's we're gonna change. Yes. Yeah, it's a great question. I'm glad you asked this.
I asked that question, thank you. I asked that question because growing up, I think 60s, primarily 70s, we had neighbors in Red Mesa. This is actually starts to make sense. And I'm certain there's also where you had automobiles from the 50s, 60s that were put together, and families used to live. In other words, they take off the doors and sleep adjacent to the shade house, and that would be covered for winter. So that was the place of home for youngsters. Now I can imagine the possible lead exposure from the 1950s. And this occurred in about the 60s and 70s. That's one of
yeah, so we do know that pregnant women actually has led children is parts of the fetus. In terms of genetically similar, that we were if your parents were exposed, they have children, they children very highly likely. And again, given what we don't know, once the exposure happens, armed, start. There's some indicating the likelihood of Right. think we're, we'll skip over this because we.
Can you say skip it? Sorry.
All right, so this is one. So there are two broad approaches. First is primary, which is simply be very then the child being exposed to getting the children child somehow they shielded or covered with something that renders it safe from that contact. That is one of our program here. We a lot of our efforts at bending the legs. It's really hard to focus just there. We know that there are many teachers. So we also have secondary strategy, which is largely built around systems that look and must by death. We have to again ensure that to other children. Other children very tested. Now we want to find where they came from and to their standards. That's second. But really, what we want is one thing that if you take nothing else, you don't already notice it's not already embedded in your consciousness, is that there's no say there's no safe level of that. So we want to prevent how is it scared? We believe that. Okay, next slide, please. We have to pick up another and get all right, so they wanted to, I want to see right every child. You get a child get a test, and after some time, so what's a child being a blood make some determinations likely that the child is exposed. But two kinds of tests. One is English test. And you can also you can get a little drop of blood from finger stick or from if you're a parent or more relatives that you know that first example is a test. There's a one test. So people can also do a blood test. The test, the blood sample that you refer to, and then that too analyze. And you analyze primary conditions using that. There are some challenges with there's a lot of advantages with systematic. One is that super expensive and to be accessible. But I think we're the running system for yourself. So you can't. The alternative would be to go to a lab and do a litmus test for the child's brain, for the child's brain, yes, to kind of be and then set out to the lab. Not only did our brain on and fire and drawn out the results take on time. So we still have a drop off in testing when it's the lab versus the big drawback with the obvious test, the fingers test, the big drawback is that it is with that hands also get if we were to just, most of us, I am fairly certain that all of us would probably do this. So to do the fitness test and get reliable results takes a whole lot of care of washing all the hands of the feet, like they all take lead free. Because any of the level tubes, when we're looking lower, so that's the point. But I'm used to say that this is the idea of making tests more good. It's also a very key part of this. Whether it's more widely. Next slide, please. All right, so we should get and I kind of touched this, but let me just say that if the child is enrolled in Medicaid, it is a requirement, not a recommendation, it's a requirement of the child gets 12 months of education. And anytime it's the 1-year-old, 6-year-old, there's no document, no test for that child's medical. The child is well, it's a little different. The requirement there is easy. It's probably testing is based on identify kids that are most likely. And kids that are most likely to get exposed. And when I first saw it, it's to be great. What are some of the characteristics that we already discussed that would make kids more likely to be in the United States? Age of the whole, brilliant. Another thing, something else. Yes. Sure, yeah, exactly. Where you live, if you live near our stuff, that should be increasing. Something else. Moms and mothers. Yeah. One more. There's no other. One more. One more. You're right. Yeah. That's right. So there are communities that are bases lower, inflated. People look like me. Kids who look like me. They're more like those factors, not in the just they have students PhD to your child, you'll be thinking about all those dimensions as they do. Next slide, please. And then once the test is done, they provide them some things, education. They can connect the child and children to the service level. Harms way happening. He's not what is the but they could do things that they could also look at treatments, incubation level of and referring to social service and hearing, that also, one of the things that next slide, please. So there are things that we can all do, and those things. Actually, I will because it's easy for be able to exercise, keep some control on your own circumstances. Part of it, right? So, first thing you want to try, doing that in your home next year as possible. Somebody mentioned this morning, I hadn't heard of this before, but but we do recommend on our website. This is that you find or certified that state credentials. If you're in a older, major renovation. As a matter of fact, even just a renovation as a consultant. In many cases, people sign us yeah, we don't really need to hear their person. So, people obviously are one of the situations was fortunately fishing and all of a sudden children this was the first noticed that children's love and we started wondering what's going on with this homes, and then we started asking what's the occupation of the parents? And we found out that part of them needs fishing. And we went there, did some investigation. Work this volume. They're basically getting included basically just like sections. Like they're bringing their work clothes home and so yeah, there are things like that too. Have to be something friend. Just to advise. Chicken drinking water, like I said, it's there's no monitoring for something to do. So that's if you got big like a yard that has just beer solid, it's going around. Especially if you're big community where it has been started and sources. Then you want mulch. Other things you can do. This one is really important. A lot of people are going to be aware of this. But, children that have good nutrition, getting calcium, tend to absorb lead very good. Lead will go in. As the children are nutritionally deficient, calcium and this compound. And sitting it in and then just really something. They're actually convinced by calcium. Just making sure there's good hygiene, washing your hands, towels. You know, get outside, putting more self videos. Really good things to do. You know, try to make sure as much as you can when you eat what's products can stand trying to do something. So for example, if you like the one, you can use that language. So you might, you know, use it similarly for you use that. It's really helpful in a event. Child exposure, also someone mentioned about washing your food, you know, your food is on the start, saw it as you go to contaminate that, and it's not a starting. So if you don't wash it, so and then you know, getting your if you're concerned, or if you know, talk about exercise, try condition of parents say, I'd like to have exercise. You know, it's a really good thing to do because again, it's just keep it natural. There's no safe. There's no safe. So you know, you want to know. What you do something else. The exposure doesn't just stop. As happens. Create your basis for cardiovascular diseases. So it doesn't hurt you. Okay, next slide, please. Well, we know that that there are certain, you know, challenges. Travel communities might have these problems. Distance giving, having the tests. You know, there's challenges where we get sometimes there's also the issue of choice. Insurance status. That's why I think we can they better testing even more widespread. We don't know the solution yet, but we are now starting to make the kind of solution. Next slide, please. So we're gonna jump over this one because I think I should do this 10 minutes and I'd like to have a little time. So we just go to the next slide and you just see here all this part. It's all in previous slides there are visions as I describes no individuals. This is all we want to make sure we protest. You know, the risk for exposure gets. We also want to make sure we But I was reformed, already, develop their we also wanted to do population mentions. And I was really keen this morning when we were talking about EPA's program, getting population, getting community organizations involved, getting people involved in this journey, being part of our programs. So we're running population-based policy. And then last but not least, we want to make things honestly and then child's in schools. We want to make sure that whatever it is, it's about take care of it. Next slide. Here's something that we've done that is kind of driving us towards more of their testing. With a lot of reference value to get too much. But just to say that it's a policy tool that we use to identify children quantify our greatest risk on low on one reference value, right? We continue to improve our surveillance and efforts and our techniques We're expanding the partnerships, building partnerships, trials. People in our Pacific Island territories, we're being very vigorous outreach to try to bring more partners to the table, not just in the States. And then, last but not least, we have two that's soon to be deployed. It's called the Legacy Winter Index. What it is that anybody will be able to go and bring your community's census tract, or just go online and publish your person over your state or your county or pretty good. And then you get a score, you get this score, or next. It's it's not like your personal risk, it's an index based on that varies number of variables that that's coming soon. Anyway. It's like this is just a map that shows how the CC's funding of letters it's pretty much across the United States and also extends to territories. Who are already funding under specific those funding each one is one. And through that mechanism funded 47 states and 12 local jurisdictions. Since that time, we've also established relationships with the 3 states that have now reached the and we also have additional funds that we want partners be out to build connections with tribes and territories. We also have going jobs and partnerships. Next slide, please. All right, so I'm just going to say that the surveillance efforts that we do is really very vital. That is our best means of identifying where and how effective our policies interest in this one. And it also build relationships with the products so that you know where what resources each of our products might be interested in. I'm going to skip over the next couple and just go to our summary slides. In summary, there are a lot of sources that we know are very common in society. And along with that, I shared several people chime in some additional sources. How many people know that there's lead counties? Anybody? Yeah, so they, some, I don't, there are some that have lead based. And there are cases where created from taking partners. And who likes to play accounts? So, there are resources that we just some really services. All right. We're taking children is very important. Blood test is the best way to care about the fingerprint test. But we use this very hard, so we find out what's possible. Get the fingerprint test first, the only way we CDC is good to make it. And we are very, very interested. In 2021, we issued our last list of funding opportunity. Was trying to originally were not as of and recent. We did want to have to change that. So then tried to put it. We didn't end up having any trial. We all stuck there. And we doubling down. We are moving that. So with that, I think that's the and on one slide, the last slide has some resources. And I believe all of my slides we are shared with them. Does anybody have any questions? Sure.
Kids that are already I'm sorry, can you elaborate on how that would work with Native American populations? Because I work for a managed care organization in Mexico, and I know Medicaid laws vary from state to state. In New Mexico, the states have state preference to Native Americans. They obviously don't have to sign up for a Medicaid or select an MCO. Native Americans are exempt from that until they sign up for MCO. So how would that work in a state like New Mexico?
So I'm going to ask, let me make one comment and I'll try to answer. But my maybe it's for New Mexico. But what I actually said is that the children who are making why the actual fact of the matter is that they're not getting nearly the rate. There was an OIG report, General Agency, the study 2 years ago. It's called Medicaid. And they found that the compliance report is somewhere between 40 and 50%. So a lot of people and specifically for New Mexico, I know there's different states have different ways in which they implement programs, like so we have specifics on that. But it's a serious rule. If the child is medicated, needs to be just 12 or 24. And if there's no documented record of test, it's the 2 years. Thank you, everybody.
It's actually for the audience. I know Paul mentioned during his presentation with the new notebook that we did not get any applications from tribes. So let me ask you moving forward, and Paul did say that we're going to continue to work on that. What suggestions do you have for us to get the word out? So we can get trials to apply the money that's available.
I would, especially here now, I would recommend a presentation for the health education and services committee. I mean, or even just kind of, I'm sitting here texting the vice chair of the health education and services committee. So now it's a way more visible, and I so much great information you guys are presenting that I feel like this is the mark. So if at all possible, I know we have 500 in emerging tribes information, but at least trying to get a presentation to them as well. It's great, I think.
So, Fantastic usually on a yearly basis provides a resource for all CDC centers, students and offices. Kind of talks about what's going on in Indian country. We hope to have a new one out this February for our tribal advisory board. This upcoming February, we do have a new member from Navajo on our tribal advisory board who will be into our meeting in our tribal advisory board meeting in 2 weeks. But that's another great place for people to get that information. Anybody can call in, listen in. So I do encourage people to do that. And again, you can always reach out to travel support at cdc.gov. And we are more than happy to provide information to people as needed. Thank you.
So Joanne, correct me if I'm wrong, but I think sure.
Yes, I just wanted to say that on honorable the secretary services will be station. The application information that speaks to ways and means.
So
I'll just add, one way that I'll speak about the climate health program in a few sections, but that we've been able to get funding out to tribes through National Indian Health. So the application process tends to be not as it covers them, yeah, and a little bit more targeted. So they have a engaged network with the tribes. Just wanted to, I guess, put that out there for both CDC and for others. National Indian Health Board does have CDC funded opportunities that
yeah. So Joanne, for I guess our next round, cycle in the no-go, yeah, we can work with your office to help coach.
The next presentation we'll be having is safe water, sanitation, and hygiene in Indian country. This section is about access to safe water, adequate sanitation, and hygiene are basic for health and well-being. Many communities, including American Indian and Alaska communities, for instance, lack access to these basic services unless progress increases. Representatives from CDC and CEH and NCSDR partners and others will discuss technical assistance in water sanitation and hygiene interventions that address problems with private drinking water systems. These interventions include building capacity to identify hazards for inspection of drinking water and wastewater systems, responding to and preventing outbreaks, fulfilling crucial functions during emergencies, such as water supplies. Our speakers for this session, Keisha Hawkins is an environmental specialist and grants manager for the Choctaw Nation of Oklahoma, where she has been sampling for PFAS and PFOA chemicals on the Choctaw Reservation for the past 2 years. Keisha is an Oklahoma native and Choctaw tribal member. She received her bachelor's in science degree in natural resources and master's in agriculture from Oklahoma State University, and is a graduate from the University of Oklahoma Law with a master's in oil, gas, and energy. We have Captain Troy Bear. He is a water systems subject matter expert at the CDC's National Center for Environmental Health. His duties include managing interagency agreement between CDC and IHS Division of Sanitation Facilities Construction for transfer to CDC. He spent 16 years working for IHS and Alaska's tribal health organizations. And we have Dr. Rachel Rogers. Dr. Rogers is a senior health scientist at NCH and NCSPR in the Office of Science and serves as a scientific for the NCH NCSPR PFAS community of practice, and she has been with NCH NCSPR since 2008.
You know, I like to watch those apocalypse. This asteroid crashing to the earth, zombies, mega volcano, and humans have to kind of rebuild the civilization and save things. But there's one thing that all of those movies have in common, and that is no matter how bad things get on Earth, in those movies, the water always turns on. Anyone see the Bird Box? It was out pretty recently. And I was watching this just the other day. One of the other ones on the air. And you know, the world was pretty crazy. Everybody had to wear these blindfolds and we were going crazy in the street. If they kept taking showers and they washed their hands. Apparently, whatever was going on where everyone else had to wear the blindfolds didn't affect the water plant operators because they could still read the chlorine test and, you know, turn the levers and fix the leak pipes. So I just thought about that and thought how different it is. That here in the real world, where it actually takes a big effort to establish water service and keep that water flowing from the. So, you know, today I'm going to talk about, you know, some of the things that CDC is doing to help establish water service and help you operate systems. Some of the partnerships that we have the one with the health service. Now, if you look across the United States, most people in general have water service. But it's Alaska Natives and American Indians are the group with the lowest percentage that have running water. And then you can go farther than that and say, you know, we're also the group that has the most difficult time in operating those systems and just getting the infrastructure that will have to work with the water. So it's a big job. And could you, do I have a clipper or does someone
I have.
switch it for me? Oh, I'll just give you a sign.
Yeah.
Right. So today what I'm going to talk about primarily is work that's being done for CDC, the National Center for Environmental Health and CDC's Integrated Health Services. You know, for the most part, Indian Health Services provided both by subject matter, environmental health, and by profession, engineers, and But there's one kind of pothole that's me, where I'm an environmental officer, but I work. And that's kind of a little bit of a source of pride for me throughout history. And a little bit of a rivalry between those two groups, but somehow these three folks have accepted. You know, I wouldn't say they like me, but they want me to figure out. So that's getting good. And today what I'm going to do is talk about some of the change the slide.
Sorry.
So what I'm going to do today is really talk about 5 projects that the CDC is doing through this year. You know, Indian Health Service is a direct service provider. And they have people out there that the hospitals, the environment, have things to do, where they're not doing that job in that case. You know, our jobs at CDC are a little bit, you know, we're not direct service providers in the same way. So what happens is the Indian Health Service folks get focused on all these daily jobs, and they often don't have a lot of special jobs, you know, or look at threats. You know, for example, you know, the Indian Health Service folks just came to me and said, you know, keep us. We need to and not being so reactionary that we have a strategy addressing things like this in our water systems. You know, so a lot of that it changes life. You know, the first project that I'm going to talk about today, it involves really one of the most important things that happen, and that is being able to show the benefits of our what's the impact. You know, because everybody knows that the building water systems, the maintaining and operating systems is expensive. And there's people, even people at high level in Congress or the federal government, they don't think we should be spending much. And it's a daily fight to keep that money going and to make sure that they're shown. So this is a project that I started in probably 2013, and it was 2015 before we really got it working. This project estimates the diseases that are prevented in terms of respiratory infections, skin infections, infectious diarrhea, and the healthcare dollars saved for every project that's covered by the now, it also compares the healthcare cost savings with capital projects expenses to calculate a return on investment. And every year since 2020, been reporting these estimates to Congress as part of the Indian Health Service's congressional investigation. So what will happen is the Indian Health Service makes a request to Congress for money that they want this coming year for building water sanitation infrastructure. And along with that request, we provide a test of the diseases prevented and healthcare dollars saved that will result from those dollars. It's been pretty effective and powerful. And it returns. This is just going to show, in general, what IHS spends throughout the years in terms of projects per person per home. But you can see here in the third column, it ranges between 140 million to about 328 billion. Now that stops 2024. This year, the numbers are very much different because as a result of the infrastructure bill, it's about 1.2 billion for 3 or 4 years. So it's a big difference. But this is what we had. Next slide, please. Right, so this slide I really want to focus on return on investment. And you can see here that the return on investment varies by year. Another way to say this, for example, if you get 2000, if you were to spend $1 on installing water and sanitation services in Indian country, get back $1.20 here cost savings. So it's a positive value, so that's pretty good. Also, the numbers vary through the years. 4% at the lower end and 23%. 2019 is kind of an anomaly there with its 2% of that investments there. You know, I usually do this work sometime around February or March of the calendar year. You know, 2019, I was working on in March of 2020. So that was the further than so those numbers, we couldn't get all the data out there in that numbers. This shows something. Next slide, please. Here I wanted to show some very specific results. I know that they're high test areas, but this shows how big Nashville this year, in the Nashville area, goes from Maine all the way down. 141 projects funded. These projects serve over 10,000 homes and 34,000 people. 58,000 cases of disease by either building or infrastructure. So, and next slide, please. Just go to the Bemidji area. It's hard to compare areas in terms of so the Bemidji area, 39 projects funded this year, 5,000 homes. We serve 21,000 cases. And good. Next slide, please. This next slide is titled. It's project. You know, it's important to understand. First of all, I throughout this report, it's really important for our industry, but it just means the operation of the systems. Now, one thing that you have to understand to get this is federal agencies, including Indian Health Service, EPA, U.S. Rural Development, pay for installing the infrastructure, the initial upfront cost, but they don't pay concrete and maintain the system. So that creates some challenges, and sometimes you have premature repair, placing of the infrastructure just because it wasn't properly taken care of. So now we're at a time when Indian Health Service in particular is considering providing operation and maintenance support to tribes, financial support. And the Indian Health Service director, the new director, asked a question of me, and she said, you know, what would be the impact of the capital projects expenditures if we were to fund the operation and maintenance? In other words, what if we weren't paying to prematurely repair or replace the systems all the time? Why don't we just maybe fix them as we go? Would that be cheaper or expensive? So that was the task I had. This is kind of a study. I'll show some quick. Next slide, please. This is my general approach. I started by obtaining a data set of 390 projects. When reviewing each of those projects, they contain information about the project itself. And then I put them into one of four mutually exclusive categories that I'll explain in the next slide. These are the four categories. I mean, this is kind of small, but this first category are the projects that would likely be avoided or not if you were to provide what I call excellent operation. Yeah, these are your real cost savings here. Now, the next one would be partially avoided. Sometimes the project is divided into two different scopes. You know, you can have one project that's doing two things, and they get two different repairs. Those repairs can have causes. So sometimes I had to split them. Number three, these are projects that would not be operation. For example, those are projects to deal with Population expansion, or maybe engineering efficiency of the initial project, or maybe there's new technologies along that just needs to go. So this would affect the result. And then category 4, some of these projects actually there wasn't enough information written in the project description for each of them as to what would happen if there was operating. And we could go to the next slide, please, and show a little bit of the result. Here's what I came up with. About 44% of projects could have been avoided, or at least temporarily avoided, if operation and maintenance had been provided. A big result, really. And for example, a lot of these projects are things like now in a well-operated system, you have an ongoing leak detection and repair program. You have a crew or person or several people that go around and do this as part of the company. And they fix it. So in theory, you never actually have to come in and replace them because now they're leaking. The other thing is just don't repair them, let them leak like a sieve, and then when it gets so bad that you can't operate anymore, ask any health service to come back and replace them. That's kind of so that's kind of the result there. But $62 million and another $16 million from the partial. So that's a big start. It's a pretty big operation program if you were to start. IHS is authorized to support operation and maintenance, but they've just never been funded to do so. So this is something that they can use. And next slide, please. One of the things that I really wanted to emphasize back to IHS is that this is just an initial analysis by one person using 1 year's data. And I'm not even IHS program. I just employee. So I really wanted to stress to them they need to do some other things. And I left them some recommendations. First of all, I say you need to really define what operation and maintenance is, or what an operation and maintenance program is. Specifically, what are you going to do? And then you can better tell with that. You should expand the team to IHS staff, formalize the code book and process. And then apply this methodology to other years of cycles. And then I think that we need to recognize that operation and maintenance is not just a matter of dollars and cents, but well operated and maintained systems also go further in preventing disease. So we need to roll in those health outcomes in the year in a similar way to project. Next slide, please. Now, with this slide, I want to start talking about another area, and that's what I would call transitional infrastructure. Now, in past years, there's been two kinds of water infrastructure, permanent and temporary. Now, permanent infrastructure is what we all know about, and it's also what everybody knows. There's also some reasons why some tribes and can't have that way. In some cases, in many cases, the technology that we have available just doesn't fit the circumstance. Got, for example, 6 homes in Creek, Alaska. Those 6 families decided to go on the other side of the river. Can't bring a water pipe across that river. And 6 homes isn't enough to build something. There's no bridge. So what do you do for those families? You need something else. Now, one potential solution is what we call temporary infrastructure. But that has been not embraced both by tribes and by Indian Health Service for a couple of reasons. One, federal funding can't be used to build temporary infrastructure. Can't do it. But also, even if we could, tribes have said they don't work there. And the reason is with the scoring system, priority list to get new infrastructure served is called the sanitation efficiency system. And it uses a numerical scoring system And tribes or homes that have nothing go to the top of that list. Now, if they were to be provided temporary infrastructure, they wouldn't stay at the top of the list, they already have something. They would be outcompeted within that list by other tribes here. Even though they have this temporary stuff that is. So during the pandemic, there was really some things that we developed this new class of infrastructure called transitional and got a few projects. This fills the gap between permanent and temporary, just provides the bridge related, which is pipe water. Demonstration projects in Alaska and the Southwest. That's the first. Next slide, please. This is called the mini pass. Pass stands for Portable Alternative Sanitation System. And back years ago, when I was working in Alaska, we wanted to provide water to a little village named Kivalina. So Kivalina had a problem in that it was being wrecked by climate change. And I'm pretty sure that many of those homes were going to wash away. And Congress came out with what we call a blacklist. If you can't spend federal dollars to provide infrastructure in these communities, but because maybe they're not even going to exist in the near future. So we developed a system called PASS, Portable Alternative Sanitation System, with the key word there being portable. Our idea was we're going to build these all in the homes, and then right before the community is washed away, we're going to move to the next community. And we did this, and we provided some of these. Now, when there was a need to provide additional sanitation for these homes, other homes, prevention, we thought about PASS, but there was a problem in using the PASS system in that we were having the initial discussions in October. The last barge had already left. June. So you couldn't get the pass system into these villages that were flying away, that there was no other way except these smaller areas. So we made a new system that really is just a downsized, smaller version of pass that'll fit in a smaller. It's similar to what you would have in RV. You know, there's a working can sink there, 20-gallon gravity fed tank, top of that cabinet, and in the bottom, you know, it's just really a 5-gallon bucket that the gray water runs into. Now, just like an RV, you know, there's not a pipe stuff here, stuff here, out, but you got something there. This is better than we installed about 400. Next slide, please. This kind of shows you what we were dealing with here. You know, on the 4 slides there, that shows you what and that's a honey bucket there. It's a 5-gallon bucket with a toilet lid. And a little water. Pour water on the picture there. On the right there, you see that. Better. It's not what you want, but at least until we can figure out how to install permanent infrastructure. Next slide, please. Another home. This home didn't have a bathroom, so we had to get a little bit creative here. You can see that we're there in the corner there. You see the honey bucket, the 5-gallon bucket. Now on the right, you've got the mini passes. Improvement. Next slide, please. All right, now this is some work we did with the Southwest tribes. This is just what we call transitional water points. Now, a water point is just a distribution point where family without running water in their home and fill up a container with water and take that back to their home. Now, especially when you look at places like Nashville, there's difficulty with these homes. It might be just one way to get to the nearest water point. So it's really difficult for families to get here. We also had some trouble with installing more of these because the aquifer is already stressed. And sometimes those wells are 2,000. And there's also a lot of restrictions in drilling new wells on tribal lands there in terms of bidding and such. So this is what we call the transitional water point. It's got a maximum of about 6 gallons per minute. That's not what you would want. You can't fill up your truck size water tank, but you can get small containers. And this taps into an existing water. So we did have. We installed 59 of these. They sort of came in a bundle of 60. The 60th one is in the CDC. And this reduced travel time on the bundle by 40 minutes. Next slide, please. Legionella. You know, Legionella is one of those. It's an old disease, but it's also kind of an emerging in that the rates of it have been dramatic in recent years. I don't quite understand why it's got a lot of attention. And you know, the larger water systems. First of all, Legionella can grow in improperly maintained water systems, including community water systems. The larger systems have gotten pretty good at preventing Legionella, and there's also a lot of guidance. But the small rural tribal systems don't work quite the same. They needed specific guidance on how to prevent colonization of ice within those types of systems. This is something that I wrote a little guide here who works with the Alaska Native Tribal Health Consortium. And this is validated, so we can sit down and share this with environmental health folks, tribal water operators. It just provides practical guidance to prevent Legionella of those water systems. Next slide, please. Talk about this has been a project that I've worked on for probably 4 to 5 years. It's not perfect. And as a matter of fact, probably not even halfway. But my boss Jeff Smith said, a good idea is to so I'm going to continue to work on it until we have some success, because I think it's really the Indian Health Service has 2 different electronic data systems that have been drastically improved in the last half. You know, we've got the sanitation tracking reporting system that provides household level data on water systems. And we also have, of course, the electronic you know, what is being proposed within the Indian Health Service headquarters is a way to merge these 2 things. You know, a way so that a physician at a hospital can see the quality of water that that person is receiving. You know, could you imagine having something arsenic? Where the physician can say, oh, yeah, precursors for diabetes. And your home also has is a risk factor. And going the other way, you know, we've been looking to big, large scale evaluations or research projects to really determine the health benefits of water sanitation. But this would make that much easier for us. So continuing to work on this to help have success. Got some slide, please. This is kind of the end of it. You know, I remember once I was there with my family and also some colleagues that was kind of posting about how much it is about water. And my daughter was there. She was about 6 or 7 years old at the time. She said, "Dad, does water ever take a nap?" I thought about that. It's okay. I have a question. But most questions I can't. So if we have someday, unless we're going to do that session. Any questions or comments? I don't see any hands up. Either answer every question. Whatever was. We usually have a shade here.
Hi, good afternoon, everybody. Is it on my slides? Okay, so it's so nice to see you guys. It's, still waiting for me. My name is Rachel Rogers. I'm the senior health agency tax substance registry. And my part of this panel is to talk about contaminated water contaminants. They are found in the country. So the class is called PFAS, or polyfluoroalkyl substance. And I've been working on PFAS at ATSDR for a decade. I'm here to work to help communities start facing contamination with PFAS. And as was mentioned, I serve as the technical lead for the ATSDR PFAS practice. In that capacity, I technical oversight and guidance for all of the PFAS work. So grateful to be with you guys today to talk about this topic and to share a little bit of ATSDR and Nashville. Okay, so I'm going to start out just very briefly with a little bit of information about what ATSDR is, what we do, and then I'll talk about PFAS, what they are, and hear about them. I'll wrap up with some information about the bigger projects that the agency has related to PFAS, as well as some resources that we've developed to help dealing with concerns about exposure. Next, please. Okay, so ATSDR, or the Agency for Toxic Substances Entities Registry, is a federal public health agency that is a part of the Department of Health and Human Services. We are a sister agency of the CDC, and our primary mission is to protect communities from exposure to harmful contaminants, and to do an assessment of what contaminants are present in various communities and determine whether or not those contaminants pose a risk to human health. Ultimately, our big overarching goal is to reduce morbidity and mortality related to those exposures. We are headquartered in Atlanta, Georgia, which is where I come from, but we also have 10 regional offices in the country. Our regional offices are really the first line. Our regional representatives, and some of whom are here with us today, are really on the ground in the communities that we serve, and they serve a very important role as liaisons with federal partners, with local and state, territorial health agencies, and they are critically implementing our programs and leading our activities in this country. Next slide, please. Okay, so what are PFAS? Right off the top, I just want to start by addressing the fact that this is a very weird acronym. For polyfluoroalkyl substances, it sounds like one chemical, PFAS, but it isn't actually substances. So it sounds like one chemical. It really, depending on who you're talking to and what definition that person is using, it could be as many as 9,000 in the class. The class is characterized by a long carbon chain that is either partially or fully fluorinated. So where you would have a hydrogen atom bonded to the carbon, instead you have fluorine atoms. The carbon fluorine bond is one of the strongest in organic chemistry. Because of that, PFAS are particularly well suited for use in consumer products as surfactants and dispersants. They're used in firefighting contact materials. They're very. The other interesting thing about PFAS is that they are incredibly persistent. So when they get into the environment, they tend to stay there. And when people are exposed to them and PFAS get into people's bodies, they tend to just get stuck. They bind the proteins, they stick around circulating body via the blood. Next slide, please. So this is a really nice schematic of the state that I think is really good job of illustrating some of the ways that PFAS can get into the environment and lead to exposure. So PFAS manufacturing facilities can discharge PFAS directly into the environment, into source waters, rivers, and lakes. We also can have discharge from wastewater treatment plants directly into the environment. We also know that wastewater treatment facilities produce biosolid sludge that is often contaminated with PFAS. That sludge can be disposed of in landfill, but it's also often used as soil cultural materials. And by both of those mechanisms, PFAS can seep into the groundwater and contaminate water sources. They also can be taken out of plants that are eaten by people and also by reproduction animals, things like cattle and worms. So through all these mechanisms, PFAS can get into the water supply, both private wells, but also we also know that people who are consuming food that was grown, raised in areas with PFAS contamination can be exposed in that. Next slide. The primary PFAS exposure pathway is ingestion. So we know that people that live in PFAS contaminated areas often have PFAS in their drinking water. As I just said, we also know that in places where PFAS are made, we often see PFAS in locally food, we see PFAS in fish, game. We know that people can be exposed to PFAS via incidental ingestion by accidentally swallowing PFAS contaminated soil or dust. We know that people are exposed through the use of consumer products. In particular, there's been a lot of research recently about contact materials. So pizza boxes, waxy paper that wrap your hamburger in a fast food restaurant. Those can be sources of PFAS exposure. We also know that PFAS cross the placental barrier, so babies that are born to mothers who are exposed to PFAS are exposed to PFAS in utero. We also know that PFAS partition into so it's also an exposure to babies or to those who So for individuals who are concerned about their PFAS exposure, the most impactful thing that a person can do is spend some time thinking about how they are currently being exposed and what they can do to reduce those exposures. So, in most of the communities that I work in, the biggest thing is drinking water. So people who are concerned about contamination or concerned that they may be exposed to PFAS in their drinking water can use an alternate source. They can switch their water source altogether. There are also a number of filtration options that are shown to be effective at removing PFAS if they are maintained according to the manufacturer's instructions. So Brita filters, picture type filters with activated carbon, those are fairly effective. They don't work if you never use the little cartridge. There are also places that have contaminated fish and game. We've seen fish advisories in many places. We've also seen advisories for like the caught deer. We've even seen advisories for wild turkeys. So paying attention to the local advisories around consumption of fish, game can be another effective way to reduce exposure. There is still PFAS in some consumer products. So we also advise people to be informed consumers to the extent possible. Now, in this country, the use of long-chain PFAS, like PFOA and PFOS, has largely been phased out. So it's harder and harder to find a Teflon pan, for example, contains PFOA or PFOS. But that doesn't mean that there are other members of the class. So paying attention to product labeling, contacting the Consumer Product Safety Commission to avoid exposure. Next slide, please. So this is one of the first, this data that you see on the screen is one of the first investigations that really opened public health communities as to the extent of the PFAS contamination. This is primarily, actually this particular data set is only looking at drinking. And it's data that comes from the EPA's unregulated contaminant monitoring rule, which is a rule that at this time required any municipal water system that served 10,000 people to sample for a list of 30 unregulated drinking waters. Now, in 2013, third iteration of this rule took place. 6 of those 30 contaminants were PFAS. This is the resulting data. But we saw that there were 51,000 water systems that were tested at the criteria. Of those 51,000 systems, 4,800 were actually sampled. Of those 4,800 systems, 129 systems had any detectable PFAS in the water, and 65 of those systems had levels of PFOA and PFOS that were higher than the health advisory that the EPA had established at the time. And so what that told us, the public health community, was that 6 million people in the United States were drinking water that was contaminated with PFAS above a level that the EPA considered safe. So this was obviously a big deal. What's really interesting about this data, though, is that if you follow your eyes down to the bottom of this graphic, you can see the numbers, the estimates, and the number of water systems that were tested. So that includes private wells, that includes smaller drinking waters. And when we look at those numbers, you see that there were 60 million people getting water from drinking water systems that were part of this. So while this data really got our attention, it was by no means representative. It didn't tell us the whole story. The other thing I'd like to call this group's attention to is this paper that you see there on the screen. This paper did a really nice job of looking at federal PFAS testing, specifically in tribal water systems. What they found was that this rule sampled of all of the tribal water systems, 3.2% were tested as a part of this program. That represented about 28% of the tribal population. And so that's primarily a product of the fact that tribal water systems tend to be small. This program only required sampling water systems that serve more than 10,000. Now, the good news is that EPA is currently in the process of implementing a fifth of the contaminant monitoring. And they have made some changes with lowering that. So now any system that serves more than 3,300 will have to test for a list of 30 unregulated drinking water contaminants. And of those 30 contaminants, 29 are PFAS. So we are on the brink of getting a lot more data. And what the estimate suggests is that in this new iteration, 12.9% tribal water systems will be tested, and that will represent approximately 64%. So that's really great news. And actually, the data from this program will come out batches over the next 2 to 3 years. But the first batch just came out last week, so it's really exciting. Can't wait to get to it. It's really good. Okay, next slide, please. Okay, so I also want to call your attention to a couple of resources that provide a little bit of additional information about PFAS surveillance in tribal communities. So this map that you're looking at is a screenshot from the EPA's Tribal PFAS Drinking Water Project, which is linked on the bottom of the slide, which we share. And so you can go take a look. This is a voluntary program that tribes can participate in, and it basically provides water sampling for 25 different. So if you go to the link, you can really interact, play around, filter all of the data based on region and tribe. And it's a great resource. It's not enough, but it's So I highly recommend checking that out. This is another resource that I think is really interesting. This is not CDC data, this is not federal data. It comes from an environmental profit advocacy group called the Environmental Group. Basically, what this group says was create an interactive map that shows the spatial relationship between tribal lands and either known or suspected PFAS contamination. And so when they overlay those pieces of information, what they found was that there are 140 confirmed PFAS contamination sites within 5 miles of tribal lands, and there are over 2,000 suspected PFAS contamination sites within 5 miles of tribal lands. So that's, I think, really important information as well, and it also and that's all. So the health effects of PFAS is hard to grasp PFAS exposure and health because there is just so much information coming out so quickly. There are also 1,000 different PFAS, most of which have been studied. There's also the fact that the animal models that we do traditional toxicology tests behave very differently. So PFAS then, so the pharmacokinetic behavior of PFAS in rat animals, like wildly different. And that makes interpreting the results of traditional testing in context of but that being said, there is a very strong body of evidence that suggests that PFAS exposure is associated with health effects in many different ways. In particular, PFAS exposure is associated with increased cholesterol levels, of changes in liver enzymes that are indicative of disease, decreased immune response in children, and decreased immune response to vaccines in children, increased risk of high blood pressure, small decreases in birth weight, as well as an increased risk of kidney and testicular cancer. So the evidence that we have is still growing. I feel like more papers are coming out every day on the topic, but it really is strongly suggesting that basically the whole. Next. So HCFCR is involved in in addition to research studies, we have site data work in just about every region that continues to grow. Overall, our work in PFAS across the country is primarily aimed at understanding where exposure is occurring and to what extent it is occurring, and then also examining the relationship between those exposures and the potential for adverse health effects. And then ultimately, we're trying to implement strategies and make recommendations that reduce exposure and help to reduce their exposures, as well as how people have been exposed in that. Next slide, please. So there's so much going on with HCFCR, and I don't have time to want to focus primarily on the activities that we have been working on over the last few years that were funded via the National Defense Authorization. The bottom left of this pyramid, you see our PFAS exposure assessments. If you advance this slide, so our PFAS exposure assessments are statistically based biomonitoring investigation. And we recently wrapped this up conducting these exposure investigations in 10 different communities across the United States, all of which are located in their current or former military installation. Now that particular parameter of this investigation, that these are all sites of military activity, we were specifically directed to select sites that met that criteria by the authorities legislation. And that's because these military installations often use kind of a firefighting foam called aqueous film forming foam, and that is specifically used to develop fires. So military installations tend to see that contamination because of these things. So we went out into these communities, we took blood samples of participants, and we measured the levels of PFAS in the blood, and then compared those measured levels to what we see in the general US population. And then also tried to identify and assess various environmental factors that were impacting. Very briefly, what we found is that they all had PFAS levels higher than the general US. It wasn't particularly surprising, but it was some really interesting data. All of it is available on the site. You can see site-specific reports for all 10 communities, as well as an aggregate analysis that combines the data across all the sites. Next.
There we go.
Okay, so the top you see our multi-site
So-
policy. So where our exposure assessments were really just aimed at assessing exposure, measuring PFAS in blood. Our multi-site study takes this separate approach, asking what's the relationship between exposure and health. The multi-site study is being conducted with partners across the country that are working in 10 different communities. These are communities with all kinds of different characteristics. They're not just military sites. They have different exposure profiles, different characteristics. And what's really exciting about this study is that the findings will be applicable to people with PFAS contamination all over the place, not just the community sources. Again, this work it's a long process to do a study like this. It is underway. We are currently in action and stage for most of the sites. But over the next few years, samples, data, and it'll be very exciting to see the results. Next slide. And then finally, there at the bottom, you see the PEACE study. The PEACE study is the first study, a study that we conducted in Portsmouth, New Hampshire, near the former Peace Air Force Base. And it's the data from this study will contribute to this study. Also, health outcomes. It is also kind of a testing ground. This one is remembered while we wrapped up recruitment, sample collection, analyzed all the samples. All of the individual participants have received the results. We are now in the data analysis stage. So we expect findings from our next. Okay, so with that, I want to switch gears a little bit and talk about a couple of resources that ATSCR has made in multiple communities that are struggling with. One of the things that we hear people who learn they've been exposed to PFAS are going to their doctors, asking their doctors questions. Doctors they do not know what they're talking about. That is a big. So to address that, ATSCR has developed resources for clinicians to see patients. Slides forward. Yes, there you go. Okay. So this was the first iteration. It's currently available. It's put out in 2019. Essentially an overview of the science. This document advises patients with concerns about PFAS exposure that really the first conversation should be taken place is how to identify sources of exposure. That comes first, pretty much. Beyond that, patients who have no symptoms, our guidance recommends that people should use standard care. Should be, following blood institute's guidelines, cholesterol screening, things like that. Care, preventative standards. Very important. People exposed to PFAS who are asymptomatic. A patient who have concerns about PFAS exposure and who do have signs or symptoms, then the doctors and clinicians using standard medical care to address those really regardless. Another thing I want to mention is on we don't recommend any changes to the immunization schedule. There are studies that show that PFAS may be associated with body response to vaccinations that might contribute to a reduced disease. Now, the guidance I just described is now years and we've received a lot of feedback from community members and themselves. And we, over the last year or two, have to update the guidance and to revise it better and to be responsible to the received. In that effort, we partnered with the National Institute of Sciences to enlist the National Academy of Science and Medicine to conduct an independent review of all of the evidence associated with the relationships of exposure and human health effects, specifically to environmental care. So that report was released a little over a year ago, in 2022. It is bold. To look at it, especially about PFAS exposure. Our agency is currently processing planning to report and updating our resources for selections for the interim. That report from the National Academy is publicly available for doctors who next slide, please. Okay, so this is another resource that we have on our public facing website. PFAS blood level estimation. So another thing that we hear from people all the time is that people want to know what level of PFAS is in their blood. Is that right? What is in their bodies? Fortunately, ACSDR doesn't have resources to give blood tests. So in an effort to address without actually going out and blood tests, we created this blood level estimation tool, which is essentially a resource for community members who want to know more about what light is. It is a user-friendly web-based estimator for the public, housed on the website, and it is designed to estimate levels of 4 different DMOA, DMNA, and DMHXS in the blood based on the information that a person knows about what's in it. So you can see a screenshot on the slide here. One of the first thing the user does is answer a series of questions about. I want to mention this tool is not intended to replace actual PFAS blood testing. It's also not intended to provide an estimation or diagnosis of the health risks associated with PFAS exposure, but it is based on a series of very, very heavily vetted models that were developed and evaluated and published through an extensive peer review process. And those models, assuming that the information that the users put into the tool is good, the estimates should be pretty good. We have 2 published papers that describe the really technical concepts of those models. In the last few months, okay, so after the user answers questions about what's in drinking water, they're then guided to a series of demographic questions. There's not a whole lot of detail here, but things like month and year of birth, weight, users who indicate that they are female or have pregnancy and breastfeeding history, so pregnancy and breastfeeding are both significant excretion pathways for PFAS. And then ultimately the users are with results, which you can see an example of here on the screen, that helps them assist them in understanding the might be in their blood. So what you see here on the screen, right, you see an estimated level. We used a Bayesian approach in the models to account for variability and uncertainty in numbers, and that is represented by the hash. So the user is basically given a range of blood levels that they can expect their blood level probably falls somewhere within. They're also given a central tendency estimate, which is kind of our best guess. Is, and that data is shown in comparison to what we consider to be the general US population as measured by the National Nutrition Institute. The user is also provided with an item that plain language to summarize how their result compares to the population. Then they're also provided with some information about the limitations of the tool. It's a model that has limitations. And they're also provided with some information about what they can do next. So ultimately, our hope is that people who use this tool have concerns about levels of PFAS in their bodies, that they will go to their clinicians, that they will ask questions, they will access additional information, that they will learn more about PFAS both overall and but also really local in their communities. And our tool provides them links to gain access. Next slide, please. Okay, so this is another resource. One of the most important things that ATL does is produce toxicological files. This is the toxicological file. Right, tox profiles. They are essentially just ultra comprehensive, extensive summary of all of the logical, toxicological on a given substance. They are constantly being updated and revised as well. This tox profile for PFAS was recently released in May of 2021, and I'll tell you that the revision is already. Next slide, please. So when there's sufficient data, our tox profile is one of the most useful things about them, especially for health professionals, is that they include health-based comparison values levels. And so an MRL is an estimate of a chemical a person can eat, drink, or breathe every day without a detectable risk of non-cancer. The tox profile of PFAS has been 4 different PFA, PFOS, PFNA, and PFHX. Those are the ones that we see most often and that we have those data. MRLs are dosing, so they are not directly comparable to drinking water concentrations, but they can be converted into what we call environmental media evaluation guides or EMEGs. Those are drinking water concentrations. And so while EMEGs and action levels, they are a really useful tool for a person evaluating contamination. So for example, health assessor might use the EMEG for PFAS to determine whether the concentration of PFAS warrant additional investigation. So they're really used as a screening tool, and they help health assessors determine further evaluation of the potential for infections. Okay, great. So thank you guys so much for your attention. I know that was a lot. I'm happy to answer any questions. There will be time at the end of the session as well for some discussion.
Hey, good afternoon. I actually have a question. I know that PFAS is all over and what's the correlation between PVC like the use of PVC pipes, getting water to different locations. And PFAS, I know that polyvinyl chloride and also phthalates, they some form of resistors for water, mercury, asbestos, or PFAS. Is there a biggest thing?
Yeah, it's a great question, and I think you bring up a really interesting issues, which, I was talking about exposure. Even PFAS are usually talking about exposure to toxins. See, it's just a big soup. It's very not specific. As far as I know, we don't see PFAS in drinking water. But we do know that traditional wastewater treatment processes water don't work. Now, as the public health community, water production work, PFAS, that is changing. So in 2016, first round of our data hit the press. That same year, the EPA issued a lifetime advisory for PFAS and the confluence of this huge data set and the new health advisory from the EPA really triggered a lot of systems across the US to implement filtration like PFAS. So creating our versus one system to its so while we don't see PFAS in the sort of drinking water infrastructure that you're describing, we do know that filtration systems that are traditionally in place because of that, PFAS for large systems and small systems.
Thank you. Earlier in your presentation, you was talking excellent. What is the sugars?
Yeah, that's a great question. That data set that I described is data set. It comes from the working group. And so I would recommend that you go to the website, they did, but my understanding of how that analysis was conducted, that they mapped sites that either have been already identified as sites of contamination, and then they also mapped sites that they just suspect are PFAS contamination. That I think that the way they determined the suspect sites were by looking at factors that are associated with PFAS contamination, things like the presence of a current or filtering installation. In many cases, in airports are places that use this specific foam that has led to contamination. Places with firefighter training areas that may have used that foam for training purposes. We also know that certain chemical companies, chemical manufacturing companies, are very likely places where there's PFAS contamination. There are certain industries that use PFAS. So my understanding is that this group matched those places and labeled them as suspected PFAS contamination sites. Based on that marking, they were able to identify 2,000, the exact number is 2,815 suspected sites that are 146 confirmed sites.
It's really interesting. It's not my friend of those things. So it just makes you wonder. Thank you.
Other questions? Well, our last, but definitely not least, center on this session.
Hello, my name is Keisha Hawkins. I'm an environmental specialist at Chalk Foundation. I work in our environmental science department, and our tribe has about 11 million acres in the southeast part of Oklahoma, about 2,000 members. And so I work in our EPA assessment grants. So we have brownfields, lead, gap, which we'll talk about, and wetlands. So this is one of the grants that we received in 2019. So if you're curious what went wrong when you have to hear me today, this is what happened. In 2019, my boss is extremely forward thinking and she wanted to start sampling for PFAS. We were awarded the General Assistance Program grant in 2019, and in 2020, COVID hit. So what we had to start doing was, how are we going to sample and how do we begin this? Because I had nothing, I knew nothing about PFAS or even lead at that time. And so we're actually talking about the PFAS sampling that we conducted and the lead sampling. Okay, you can go to the next one. Okay, so who are our tribal representation? Are you interested in sampling for PFAS or lead on your reservation? Okay, so this is more of a how-to. These guys in the room are way smarter than I am. So if you have questions about water, these are the professionals. This is more of a how we did it. So I'm very honored to be here. Very honored to get to hear you all today. And so this is just our story, and thank you for letting me share. Okay. So we applied for the General Assistance Program grant, and first we had to develop a QUA. At the time, I didn't know what the Quality Assurance Program plan was, but I figured that out very quickly. And then now they have a nice template for PFAS sampling. They didn't have that when I did it. So that's how that goes. And then we had to decide which sampling method we were going to use. And so at the previous PFAS sampling was the 537.1. The 533 method came out later, and it was actually more PFAS chemicals. And they were sampling the majority of what 533 has is in 537. There's a couple differences, and on the next slide, I'll show you. Don't move just here. And then we had to do our sampling. So we're going to go over our sampling plan and how we decided where to start and end our sampling and activities. There was 113 not water treatment facilities, but they're, groundwater wells, and these water treatment facilities, and we narrowed those down to just the public water. We found PFAS, we found lead, but we'll talk about where we found it. We had to go into we got our Class D water operator's license. We were learning about cross contamination, and so we knew that was a high probability. And so we always joked with our technicians, don't wash your hair, don't go down before you go. But we actually had zero contamination in our sampling. So, and then a lab. In Oklahoma, there was one lab that actually sampled for PFAS, and so we had to go ahead and get a contract with them. The other one I think was further north. And the issue we had with our reservation was so broad. This was in Tulsa, and we would be several hours away, and trying to ship it, the shipment would get there in time, they would melt, and it would not come in. Yeah, would not get there at the correct time, and so we just had to drive a lot of our samples to Tulsa. So our sampling locations. So you can go to the next one. So we looked at the water treatment facilities that were actually go back one more side. We looked at the water treatment facilities that were around the firefighter training facilities, the airports, and the industrial complexes. We're the only reservation that has an open detonation ammunition plant on our reservation. And so that was a big trigger for us. They have a public record of they sample for PFAS, and it is very high, but they say everything's fine. So, okay, go to the next one. Okay, so as far as the General Assistance Program grant that's available for tribes, this is a capacity building grant. So just like I was completely unaware of how to sample for lead in drinking water, PFAS in drinking water, this grant, we've had this grant for about 26 years, and it's kind of interesting. You can only do something for about 4 years, and then you have to switch over and start something else. It's for baseline assessments. It's not for compliance sampling. It's not for it's just a baseline assessment. So that's what we were looking for when we were sending across, and then it was just getting where it could be, and then we would have to come back with some different funding if we were going to start doing it. So water quality programs, drinking water programs, underground storage tanks, all of this can be conducted under GAP. So if you're driving, you're looking for funding, and you don't have GAP, please look into GAP. Okay. Say please look into GAP like I appreciate.
Next.
Okay, so this is kind of what I was talking about here. So on your left-hand column, these are the PFAS chemicals that are present in both of these methods. And then in the center column, that's what's only found in the EP 533 method. And then we left out a couple of these, but we had conducted a phase 2 analysis on a couple of sites, so we knew what PFAS were there, and those were the ones that we were looking for, and the ones that were in the 537 were found previously. So we were comfortable going with 533 and trying to find the most bang for our buck. We went into the public water treatment facilities. We have a water management program that builds really good relationships with infrastructure within our reservation with these public facilities. We kind of piggybacked off of them. We were taking on carrying the costs. We were carrying on the work. If they didn't hear from us, or if they did, we took that cost, which was like $420 per sample, and we take 2 samples, or we did. And so the water treatment facility, we're happy to have some here. So some, and these are the public ones. We were unable to get into the private ones. And that kind of gets into an issue later. So, okay, go to the next one. Okay, so these are our firefighter treatment facilities and our airports. And then the big red target is our McAllister Army Ammunition Facility. And we're not able to sample there. And the public water, or there's not a public water system around that site, but there is a private water system. So we weren't able to go into that private water system just because. So, but we did have, and what we did know, we conducted a phase 2 assessment on elder care housing and affordable care rental housing that we owned just south of that area. So when their public report, we know they have PFAS, we know they have a lot of PFAS, and they also let that PFAS flow into a lake called Brown Lake. That Brown Lake is where the surrounding communities pull water from for their drinking water. So what we ended up doing is we went to, yeah, okay, so this is the facilities that we were looking at, and then we go ahead one more, maybe back. Sorry. Yeah, okay, so this is where we sampled, where we couldn't sample the white art. Is it private, or we had a couple of different facilities that had issues that we just didn't get into. But none of these have PFAS, thankfully. That's the good news, is that we did not find PFAS very simple of the water treatment facilities. But we knew where it was, and so back to the elder care housing and the affordable rental homes, we went back there to sample. So we took 2 samples. We took a sample outside of the home, which is finished drinking water, and then we took a sample inside the home because we knew PFAS was prevalent there. We had always, since we knew about it, had installed filters, the carbon activated filters in these homes. So when I took one from the outside, I took one from the inside. Outside, there was PFAS. Inside, there was not. But just like you said, you don't change that filter. It's just a concentrated area. And so we always maintain, have maintenance plan for those. And so, but we did find it there. And we found it in the groundwater, the soil, the surface soil, and yeah, and the drinking water. So it is there. How we're going to handle that? It's yet to be determined. So okay, go ahead. Okay, so for our overall goal was to sample drinking water, and then we had a lead copper sample. That was conducted underneath this gathering. So, the goal was to just sample for drinking water, and we actually had two, sampling analysis that were not, we did not do them simultaneously. Did not want to contaminate any samples, we didn't want to, common methods or anything. So we did lead and copper first, and then we did PFAS, because it was a much bigger undertaking. So we actually sampled in all of our child care centers, and Head Start facilities. So we were looking at, when we started this, was the lead and copper rule. EPA came back and they said, no, we want you to do the 3 T's method, which is a zero policy for lead in drinking water for children. So we went with that, and it was actually a different, difference. One of the main differences was that I think in lead and copper it's a liter. This was actually 250. It's just right there at the top. So that was a little bit of the difference. We did not do them at the same time. Had 2 completely different schedules. Okay, go to the next. So these are our child care centers. Great news, there was no lead. There was no lead there, but there was some lead somewhere else. So in our grant, what we did in our co-op is we said this is where we want to sample. And if you're writing a co-op, or if you're working on grants, there's always a little caveat. This is areas of interest. And I don't know what possessed me while writing the co-op to write, hey, we'd also like to look into areas of interest. And that allowed us to go outside of those public water treatment facilities, allowed us to go outside of those child care centers. And if we thought we had to let there, we thought we could keep us. So we actually went to, it is a site, it's an old Italian hospital site. It was a tuberculosis center. The government loves to, sorry, not the government. They like to deed free land to tribes that has some environmental concerns on it. So they deeded this property, and it had several houses on it, a ton of levees paint. And so we knew there was levees paint on the houses, but we didn't know what it looked like in the drinking water until we started sampling. One of the houses had over 200 parts per billion in the drinking water. And we shut that down. But it was interesting because the very first sample that we took, we went back to our facilities maintenance and we said, hey, there's some lead here, it's above action level, and you need to put in a filter. We need to look at it, and no problem. We'll put in a whole house filter. No, that's not what we said. And so they put it on, they rip it out, they do a whole house filter, they want to tear the house down, they want to rip the lines out, just put in a filter. And so they put in a whole house filter, and go back and sample, and there's still lead. So then they're like, oh, well, we'll just rip out the faucets. I'm like, I think a filter could just do it, maybe. So they rip out the faucets, and we go back and we sample, and there's still lead. And so finally I was like, okay, just if you'll follow me, and just throw a filter in there. So they put a filter in, and no lead. So, I don't know. But so we have accomplished that. And so addressing these issues, I think they were written in our co-op and got into that, but actually going in and having this conversation with the people that are going to make these changes was a little bit more difficult. But we have been very successful. At least we now know what is there and what is not there. So we've had a lot of positives and a couple of learning moments from this. So that's about it. Can you remember something?
You don't have another one.
Okay, yeah, that's it. Okay. All right, sorry. I know that was quick and breezy, and I'm just being on a break, so I appreciate your time and your attention. So.
Any questions before we take it? All I see is Andy. You have a question?
I don't know what I just like to be able to
See, how are we doing on? So let's take a 15-minute break and come back. Are we on schedule? Take a 15-minute break and then we can come back for our last session today. And snacks. afternoon snacks that keep you awake are in the batch.